So that's also kind of been things that we've seen. So this is one of the most commonly observed types of things. Okay, oops, let me go back to this. All right, so with sarcopenia, typically there are decreases in strength that are going to precede the loss of muscle mass. So you're going to begin losing strength in your next decade of life. But unless you have a lot of muscle now because you've been a big resistance trainer, you may not really begin to see losses of muscle. You may look different, right? But you may not be quite as lean, but as you age, at least into your 30s and maybe into your 40s, you may have a similar amount of muscle until you get into your 50s and we begin to have these changes in muscle mass. Okay, so we didn't get to do this in our lab, but you guys saw some data from measuring grip strength. So you guys may think, why on earth, Dr. Black, would we measure grip strength? Well, one of the things that we know is that changes in grip strength are going to be good screening tools and good predictors of total body strength loss. Okay, in some ways, grip strength may actually underestimate the declines that we're going to see because people tend to do a lot of stuff with their hands. You got to hold things, you got to carry groceries, you got to hold your kiddo or whatever it might be that's going on because of all of that. And so you may even see more pronounced declines in like quadricep strength or hamstring strength. But the premise behind measuring grip strength is that sarcopenia results in systemic decreases, so decreases in strength everywhere. So your loss of grip strength should correlate with other muscles, loss of strength in other muscles. We have a lot of data on this, and it's surprisingly good. Okay, that as you age, if your grip strength goes down, then you're also losing strength and probably some muscle mass in other places. Okay. So I mentioned this earlier, but there is another change that takes place with aging, okay? And that is going to be a shift in your muscle fiber types, okay? And so what this means is that as we age, we tend to lose type 2X muscle fibers. We lose those muscle fibers that can contract the fastest, okay? So there's a reason that your grandma can't move as fast. There's a reason outside of cognitive decline that her reaction time has gone down, okay? There's a reason that the world record sprinting time by age group declines more sharply than the world record time in distance events as we age, okay? This is because aging is associated with a loss of the fastest muscle fiber types, okay? So we're going to see a shift from 2X to 2A. You may also see a shift in some of them from type 2 fibers to type 1 fibers, okay? So here's what I want you guys to see, and we're going to illustrate in this. These are the same people tested in 1974 and tested in 1992 that we're going to graph here, okay? We have a group of highly trained athletes that we tested that maintained between 74 and 92, maintained their high level of training. They were athletes before, they've now become like master's level athletes. We have a group that was fitness trained in 74 and tried to do some level of training, okay? But maybe not high levels that they maintain. And then you have a group that was untrained in 74 and continued not to train until over the next 20 years. And so this is the percentage of their muscles, the percentage of their fiber types that were slow twitch or type 1 fibers. And so we had some highly trained endurance athletes here. They were about 65% slow twitch fibers. They maintained that slow twitch fibers. If you look then in our fitness trained and in our untrained, they were somewhere around 55% or so type 1, and they actually gained, they look more like these, they gained type 1 fibers as they aged. Okay? Now, I hope you guys remember that we talked about this. It feels like it's been forever ago, but it was really only a couple of weeks, that you cannot train your muscles to shift from type 2 to type 1 or from type 1 to type 2. You have whatever you have. So there's something that's going on with aging that is specifically driving part of this change, and that physical activity seems to be able to stop. So we might have expected this group to have actually gone from like 65% if they look like these up to like 80%, but they didn't. And so much of this change is driven by death of motor neurons in the spinal cord. All of you right now, we're born with however many motor neurons we're going to have for the rest of our life. And as we age, we accumulate neurotoxins in the motor neurons in our spinal cord. The motor neurons that connect to type 2X muscle fibers seem to be more susceptible to these neurotoxins than the motor neurons that connect to type 1 or that connect to type 2A muscle fibers. As you age, you eventually get enough neurotoxin that is accumulated that some of these motor neurons that go to your 2X fibers will die. So you now have fewer motor neurons. So one of two things will happen to the muscle fibers that have been connected to those motor neurons. When the motor neuron dies, one of the things that keeps muscle fibers healthy and alive is a connection to the central nervous system. So if a motor neuron dies, then those muscle fibers lose their connection and they will die. Okay? They will die. The only way that they won't die is if you get a sprouting of an axon off of an intact motor unit that will then reconnect to those fibers. And what tends to happen is that this is called collateral branching or collateral sprouting, is that you will get axons that will grow off of a type 1, like a slow twitch motor unit, that will then go and connect to those fibers that used to be type 2X. When we switch the nervous system connection like this, something magic happens, and those fibers that were once type 2X now begin to express type 1 or slow twitch myosin. They become slow twitch fibers. Okay? They've done some really fascinating experiments where they will go in like cats and dogs and mice, and they go in and they cut the axons that are going, so you figure out which fibers are fast twitch, which ones are slow twitch. They cut the axons going to them, and then they swap them. Okay, and then they reconnect the axons, and what happens then is that when you flip those around, then the fiber types will switch. So there's something about the motor neuron having certain characteristics that are going to drive some of the phenotype in those. So when you have a loss of type 2X motor neurons in the spinal cord with aging, then you're going to get some level of reinnervation from type 1s. You're going to now have more slow twitch fibers. You're also going to have slow twitch motor neurons. Slow twitch motor units are going to have more fibers in them. They're going to get bigger and bigger and bigger, which means every time they get turned on, they generate more force. So that's why your movement becomes slow and you have less fine motor skills. Okay, some really negative consequences that can happen with aging. Now, what we can see though is in our people that stay very, very active is they can prevent a lot of that. Okay, and so contracting muscles keeps the neuromuscular connections and keeps the neurons healthier than not contracting them. So they function better, and you can stave off some of this if we can stay active. Okay. So there are some other consequences that happen in the skeletal system. We're going to see decreased bone mineral density, which is called osteoporosis. We will talk at much more length about that tomorrow. Because of a decrease in bone density, you're going to have an increased fracture risk. Your bones are not as strong. So when you fall down, because you're not as strong and you don't have as good a balance, you will be much more susceptible to breaking things. You have decreased elasticity in your connective tissue, right? You're going to have decrease in range of motion at the joints. You're going to have tendon stiffness. You're going to have the development of bone spurs and things that are going to be related to arthritis. And so there's going to be a lot of these kind of accumulated negative consequences in the skeletal system. And so that's going to be some additional consequences that are going to go in with sarcopenia to decrease your function. Okay. For some of these, we also know that physical activity and exercise is going to play a big role in helping us to prevent some of those kinds of changes. Okay. We've talked a little bit about some of the changes in the neural system. So think of this more as central nervous system rather than neuromuscular system. We talked at great length a couple of slides ago about death of motor neurons. So we have decreased neuron in the spinal cord, but you may also get some decreases in neurons in the brain, okay? And the consequences are decreases in reaction time, decreases in coordination, decreases in dexterity, and other fine motor skills. Okay, so strength declines and some of the consequences of sarcopenia are not uniform, okay? We tend to see greater losses of strength in muscles that we don't use as often, okay? We tend to see a greater loss of strength during concentric or shortening contractions compared to isometric or eccentric contractions. So if you measure people's isometric grip strength, that's going to underestimate the amount of strength loss that we see if we were to have a person say do a bicep curl or do a knee extension exercise, okay? We disproportionately lose strength at high contraction velocities, okay? And because of that, we're going to see a disproportionate loss of strength and muscular power. So the ability to run and jump and move in that way, we lose power as we age. And we need power just to walk, okay? So in a lot of ways, there's a strength threshold for maintaining function, but there's also a power threshold for maintaining certain levels of function. And so that's going to be an issue. And these data are beginning to change as women are becoming more active, women are becoming, we've pushed resistance training in women to a greater extent, which is a really good thing. But we used to say that women experienced greater strength decline than men. And so back in the 60s and 70s and 80s, this was more so the norm. When women worked, women tended to have less physical activity as part of their jobs, and they tended to exercise less in general, especially doing resistance exercises. We have changed some of that now. We have women that have more active jobs, plus some of the the male-related jobs are also becoming more sedentary, and we've pushed strength training to women, which is a really, really good thing. So some of this is beginning to kind of go away, and I think will continue. So that's going to be kind of the places where we see the losses of strength are not uniform. They affect certain kinds of movement. So you can imagine a scenario then by, well, if we can continue doing these types of movements, if we can train these types of movements or these particular muscles, then maybe we can stave off some of this loss that we're going to have there. Okay, so here we have an older gentleman who is about to do a oh God, he's probably not doing a power clean. His grip strength is way too wide, but he may be about to do some form of a deadlift, or may even be about to do a jerk, and so that's going to be good. Okay, so what do we know? Strength training can be really, really beneficial in older individuals. Okay, even more so than in younger individuals. Strength training is good because it increases strength and function, it improves muscle mass, increases muscle mass, and that's fine in you guys, okay? But it becomes really, really important in older individuals as we try to train and keep ourselves above this kind of minimum strength threshold to function, okay? With strength training, the idea of use it or lose it is really, really important, okay? When you are sedentary, you're going to lose more function. When you don't resistance train, you're going to lose more muscle and more strength than people that are doing some, okay? We have mountains and mountains and mountains of data now, and I'm going to show you guys just a little bit of some of the initial data on this. We have mountains of data that resistance training is both safe and effective when done correctly in older individuals, okay? People may be able to increase muscle mass up through their 70s into their 80s. Now, in your 80s and 90s, there have been a few studies, people may begin to lose the ability to hypertrophy their muscles, but they do maintain some ability to at least hang on to the muscle that they have. They may not see atrophy, but it may also be difficult for them to hypertrophy, and we don't fully understand all of that. Okay, so one way to do this is to be sliced alone and just take a bunch of steroids. Okay, so that's one way to do it. But in the absence of maybe having our 8-pack like Sly because we're taking testosterone, just doing resistance training can get us some really, really good benefits. Okay, so all of the negative consequences associated with sarcopenia and with aging, almost all of them can be positively impacted by doing some level of resistance training. Okay, so here is a study that was published in 1990. So it's a very old study. Okay, the study is older than most of you guys. It's 30 years old now. But it was one of the first studies published on strength training in people that were like 85 to 95 years old. So they're very, very old. Octa and nonagenarians. Okay, these people lived in a nursing home. They had numerous other chronic diseases or conditions. OA stands for osteoarthritis, osteoporosis. They had coronary artery disease and hypertension. So these were people that could not live by themselves and then had a host of diseases, right? They were not in a great place. We found that they were able to safely do 8 weeks of resistance training in them. They went into the nursing home. They did some group stuff. They brought in things, and they did 80% of 1 rep max, 3 sets of 8 reps, okay, for 8 weeks. And what they found were these, very, very, very powerful changes. These people were able to increase their knee extensor strength by almost 200%, okay? There was no plateau in their strength. It went up, and it just kept going up over the course of the 8 weeks. And so look at what having that increased strength does for them. Their walking strength goes up. They had 2 subjects that no longer needed walking aids, okay? 3 of them were able to get up out of a chair by themselves, okay? And they had this decrease in functional disability. And so these are going to be things that are really, really important in this particular population, okay? In 8 weeks, we were able to get rid of walking aids, to let some of them get up and out of a chair on their own, okay? And so you can imagine, as we will talk about in a little bit, you can imagine what this does for their mental health and how they feel about themselves and their ability to kind of get out and function and do some things, okay? So this was one of the first studies that we just trained one muscle group. They just did like knee extension exercise, okay? So this was a group that was not in good shape, that had suboptimal nutrition. They just trained one muscle group. They had lots of these other diseases, and we got this really big increase just from training one muscle group. Okay, so that was relatively high intensity training. And so what we were then interested in was, okay, maybe grandma, it's not the safest in an unsupervised situation. Maybe we don't need grandma doing sort of high load training. Do we really need high intensity stuff? And so we have subsequently, we've subsequently decided that we're going to do, we've tested lower intensity training. So 3 months of low intensity training, 5 days per week, right? In these older women, we found they were doing 60 to 70% of 1 rep max. Sedentary older adults could improve things doing 40 to 50% of 1 rep max. These older individuals were able to improve strength and improve balance by doing even these kind of lower weight ranges, okay? And this has again been like tested a bunch now and repeated, because people that are in this age range tend to be so weak that large amounts of gains can be had from very, very kind of lower suboptimal, what we would think of suboptimal for you guys, training intensities, okay? So there's some recommendations that are going to be in there. Okay, if we're at the aerobic system, this is as good a place as any. Let's take a 5-minute break. So we'll come back at 11:45, or I'm sorry, 11:43, and we will pick up. We'll pick up from there. Okay, so take a little break. I'm going to. Okay, let's get back into this. So we've talked about some of the aging changes in the musculoskeletal system and how that affects strength. Let's now get into what happens from an aerobic standpoint, right? So like, what's the other thing that's going to go on from an endurance standpoint, from a cardiovascular function standpoint, okay? So one of the things that we do know is that VO2 max tends to decline on average about 5 mLs per kg per minute per decade, okay? So when you guys in lab estimated, some of you guys were at, say, like 45 mLs per kg per minute right now. So by the time you're 30, that might be 40. By the time you're 40, it might be 35, and then so on. It's going to decline about 5 mLs per decade, okay? We know that simply to be able to get up and walk around and do things, that there's a functional threshold in the aerobic system of about 12 to 15 mLs per kg per minute. Okay, so somewhere in the neighborhood of about 3 METs is what's required to be able to walk around and kind of do normal-ish things. So if you're not very fit right now and you lose 5 mLs per kg per minute per decade, then, you know, if you're at 40, then it doesn't take that long for this to kind of get to there. So we need to find a way to try to prevent some of this loss, okay? So some of this decline in VO2 max is inevitable, right? Heart rate max is going to decline, obviously, about 10 beats per minute per decade. So your max cardiac output is going to decline. So that's going to lead to some decreases, okay? But you're going to get increases in vascular stiffness due to atherosclerosis. You're going to have weakened respiratory muscles like in your diaphragm and your intercostal. So there's some other things that are going to go on, and some of that can be prevented with some level of activity and training. Okay, so this is just kind of showing some of this inexorable decline in VO2 max. These folks are even out here that are in almost 80 that have VO2s in the high 20s. That's actually pretty good. Okay. So what we know, and this is a picture of Dr. Pinku's father, who is there. Dr. Pinku is Israeli, and that's his father who is there, and he does a bunch of walking events and those kinds of things. But we do know that if you can stay active, much like doing resistance training, if you can stay active aerobically, that we can prevent some of these declines. So here's what it might look like if you're a completely unfit person. You have a VO2 of about 40. By the time you're 70, it's kind of this inexorable decline like all of this, okay? The black line here, we have people that are runners that stopped training, and then we have runners that were kind of able to maintain some level of training that kind of keep their VO2 up, kind of looking like all of this. Okay, so some decline is inevitable, but a lot of it we can hold off and we can prevent. Okay, so here we have a picture. This picture is of one of the most famous exercise physiologists ever. His name is David Kostel. I think David is about 90 or so in that picture, but he could still whoop my ass at a half marathon at 90 compared to what I could do right now. So if we can stay active, if you can keep doing those things, then we're gonna have a lot of positive benefits. Okay, so even just some level of walking, we can attenuate the decline in VO2 max. We can attenuate the decline in stroke volume and cardiac output. So those three things are all going to go together. You can keep some level of mobility. You can improve the ability to perform activities of daily living. You can lower your risk of falling. You can improve your metabolic health. And by that, we mean that you can have more mitochondria. You can have better functioning insulin receptors. So really, really positive outcomes from a lot of this in older individuals. Okay. So what we're going to shift to now is an interesting way that we test function. And we show this because this is something that for a lot of you that want to go into the allied health field, if you're interested in, say, cardiac rehabilitation, or you're interested in physical therapy or occupational therapy, you're going to encounter a lot of individuals that are going to be between 65 and older. And so what we know is that there are these declines in VO2, there are these declines in strength and muscle mass, but we don't always know a good way to predict how that's going to impact someone's actual daily life function. And so a professor who was one of mine at the University of Georgia, her name was Elaine Kress, in conjunction with one of her PhD advisors at the University of Washington, they developed a performance test. And it is this true functional test where you do things for time and for how much weight you can move around, that you do things that look a lot like what people do in their daily lives. And so this is a performance test that any PT clinic, any OT clinic, any hospital could set up, and you could have people come in and have them do things and then put them through your rehab or your training program or whatever it's going to be, and see if you can get measurable improvements here. And so performance on this particular task has been shown to be strongly correlated with people's ability to live by themselves and be what we call functionally independent, which is a really, really big deal in older adults. People don't want to have to go to an assisted living home. Okay, so this is a test that we used to go up to Dr. Kress's lab and play around with this test, knowing how it was scored, knowing what to do, and when we couldn't make even when we were well functioning, we couldn't make a perfect score. Okay, so the test is called the CSPFP. Okay, and it's like the continuous scale physical function and performance test is what this means. Okay, but the key thing is here is that it gets into physical function. So I'm going to show you all some of the scores on this test that we think identify a functional threshold and how that relates to peak VO2 measured in a group of people. Okay, and then we'll kind of get into what goes into the test. But what you can see here is this is a scatter plot. Okay, and on the x-axis you have peak oxygen consumption. So this is VO2 max measured in these individuals. And it was probably measured on a bike in these older adults. We usually put them on the bike. It's a little bit safer. We don't have to worry about them falling down. And so the CSPFP is scored between 0 and 100. Okay, you can't make like over a 90. We know how the test was scored. We know the way to get the best scores, and we would in some ways cheat, and we couldn't get over a 90 on it. But so 0 is I can't basically do anything. 100 is a perfect score. And then what you can see then is, so we've plotted your score on the PFP against your peak oxygen consumption. And if you look at the scatter plot, right, you can see that somewhere kind of right in this area, right in this area, around a peak O2 score of about 20 or thereabouts, that there would be this kind of very distinct shift in a line that would best fit these data. Okay, so once we start getting under about 20 mLs per kg per minute, we're going to see this relatively steep decline in your ability to perform on these functional tasks. Over 20, and maybe if it's higher, that's a little bit better for you, but it's not a huge benefit to you from a purely daily living functional standpoint to have a VO2 that's a whole lot over 20 mLs per kg per minute. Okay, and so from that way, we've been able to identify some things with our functional thresholds. So let's talk about what you're doing on this test. Okay. In addition, I apologize, I forgot that this was here. In addition, there's also a functional threshold for strength. And this is knee extensor strength. So they also graphed people, and at about, this is called 2 Newton meters of strength. And that's actually 2 Newton meters per kilogram of muscle mass, which doesn't mean a whole lot to you guys, but it just tells us that there's also a strength threshold. So this particular functional task is able to capture for us, do you have enough strength and do you have enough kind of aerobic capacity to do these normal kind of daily living things. Okay, so there's also going to be a cognitive function portion that's going to be in all of this, and we'll get into that in the next few slides. Okay, so in our CSPFP, it measures cognitive function, so it has you do some things that are going to be there. It has you do certain activities of daily living that are going to be things that are going to kind of get at that, right? Eating, bathing, dressing, walking and transferring like from one place to another, toileting, which is going to be getting on and off of the toilet by yourself. It's going to take into consideration all of this. You're going to have balance and mobility. You're going to have fine motor function. You're going to have some level of flexibility, some level of strength, and some level of endurance, okay? All of these things are going to be kind of encompassed in the tasks that we ask people to perform, okay? So one part of this test is going to be there's a questionnaire. It's called the SF-36. There's a physical function scale, so you ask people questions about like, are you going to fall? How often do you fall? Those kinds of things. What's your balance like? It asks questions about, can you get onto and off the toilet, et cetera, et cetera. So we got some questions on all of this, and then there's going to be some actual physical testing of a lot of these things that are going to go into it. So again, we're asking people and we're trying to assess not just their strength, but how can they apply that strength and that endurance to normal activities, okay? So there are going to be some functional tests that are going to be a part of this. There's a thing called the timed get up and go, which is I'm sitting, I stand up, and then off I go, okay? Stand up, go. And you would be surprised at kind of how a lot of that stuff works. But that's going to be a piece of this. There's the senior fitness test that we had talked about previously. There's a functional reach test, like can you reach over and up and down? Like can you actually do you have enough range of motion to do things? Okay. So here's time, get up and go. Senior fit test. We talked about those previously. This functional reach test. So all of these are things that do not require very much specialized equipment and can get us a really good idea of, are there impairments that we could target, not just with exercise and training, but also with rehabilitation, okay? So here's some things with the Barthel Index. Here's some pictures from the CS-PFP, okay? You have to go up and down stairs, and you wear this little strap on yourself so somebody can hold on to you in the back. I do this with my daughter pretty much every day. She tries to bomb up and down our stairs. But you have them walk up some stairs. We would call them the stairs to nowhere in Dr. Kress's lab, but they actually had a bus painted on the wall there. This big picture of a bus. It's like you were walking up the stairs onto the bus. You do the 6-minute walk test that you guys did in as part of your aerobic fitness testing lab. Okay, we do the 6-minute walk test. You have to pack bags of groceries and then carry them. And you figure out how much weight goes in there and then how far you carry them and can you get up and down the stairs with the groceries. You have to make a bed. You have to fold clothes. You have to pull laundry out of the dryer, okay? So there are some things like that that we have to kind of get into. These other ones are just here for your kind of perusal. I'm not going to ask you specific questions, but if you ever go and you volunteer at a PT clinic or an OT clinic or something, when you get older individuals that come in, look and see what kind of assessments people do with them. Look and see how they assess from pre to post. They're probably doing a lot of things that are somewhat related to this, and this is the underlying physiology of why. Okay, we're trying to see what kind of stuff we have that's kind of all going on. Okay. Grip strength, physical activity recommendations. Okay, that's pretty much it. Okay, so there's a lot of kind of slides that are going to be here, but there's much, the information is pretty straightforward. As you age, you lose muscle mass and you lose strength. A lot of that can be prevented simply by engaging in physical activity, especially in resistance training. Okay, as you age, VO2 max declines. Some of that is inevitable as cardiac output and max heart rate are going to decline, but a lot of that can also be prevented. When you train, even if you've never trained before, we can take older individuals that have never done anything, start them on resistance training, start them on some level of aerobic training, and they can increase strength and muscle mass up into their 80s. They can increase VO2, okay, through their 70s into their 80s. They can prevent some of the loss of stroke volume. They can increase their muscles still work fine. They can increase their mitochondria. They can increase their capillaries in their muscles. So a lot of these negative consequences can be attenuated simply by engaging in some forms of training. Okay? All right. I know that was somewhat a lot of information and we went relatively quickly today, but do you guys have questions for me about that? at least like flash your cameras at me so I can know you guys are still here. That will make me feel a little bit better. Hey, looky people, there we go. Okay. All right, very good. It's lovely to see all of you on this glorious Monday. Okay, are there, Maddie, are you in your car? Do you mind me asking?
Yeah, every 2 weeks, the cleaning lady goes to our house, so we can't be in there. So I just put Zoom on my phone and got in my car.
Okay, excellent. That's outstanding. I appreciate the dedication of all of that. We have guys that come and mow and weed eat and stuff our yard, and they usually come on Monday afternoons. And back in the spring semester, it was right when I was teaching capstone, and so they go right by our windows, and it was terrible. So I can appreciate all of that. Okay. If there are no questions, please, 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 please look at the final project stuff before tomorrow. Okay? I don't want you guys waiting until Thursday and being unsure about what you're supposed to do. All right? Start looking at all of that. And when you inevitably have questions, ask me so that I can then share those with everybody in class, because it makes perfect. I know what I want you guys to do. And I feel like I have written out something that makes sense, and it makes sense to me. But my guess is it's not going to be completely clear to you guys. So when it's not clear, just get back with me and let me know. Okay?
I have a question about the project.
Yes, Corey, fire away.
Do you want us to pick only one disease, or do you want like all those diseases that are listed?
I want you to do a few slides on all of those diseases that are there, all of them that are listed. Okay?
Okay, thank you.
You got it. There should be 5, I think, that are listed. It's cardiovascular disease, diabetes, cancer, and then it's going to be the musculoskeletal stuff and mental health, okay, which we are going to cover tomorrow and on Wednesday. But the slides are already up for that, so you guys can be good to go there.
I have a question about the project too.
Yes, Cameron.
For the PowerPoint, number 1, it says required in quotes disease state to be covered. What does that like mean?
Hold on. Let me pull up what I had from all of that, Cameron. It just means basically like, are you covering the required diseases? Like, have you talked about cardiovascular disease? Have you talked about diabetes? I think that's what I mean.
Okay.
Okay. Just like there are points that if you don't cover one of the diseases, then you're going to lose, like,
Okay. That makes sense.
For the brochure, is it the same diseases?
It's the same diseases, and you're going to have to try to be concise with the brochure, right? Like the brochure, you're not going to have enough space you're going to want to try to focus on, are there similarities among all of those things where if I do X, Y, Z, I can get positive benefits in all of these things. Whereas in the PowerPoint, you may be able to be a little more targeted and a little more specific to, like some of the the skeletal health stuff are really benefited by resistance training, as you guys will see tomorrow. But in general, resistance training can be good. Aerobic training can generally be good for just about everything. And so in the brochure, you may not have enough space to be able to kind of tease out, well, for this, do this, and this one, do this. It's just like, hey, here's a rough thing of do these and these things, and that's good for all of this, if that makes any sense. Whereas in the PowerPoint, you can say, okay, this for this thing, and then something else a little bit different for something else. Okay. Anything else? Nope. Okay. Well, then you guys have a great rest of your day, and I will see you in the morning. Okay? All right. Very good. Bye, everybody.
I actually had a question over the resistance training critique.
Yes, Madison.
I haven't gotten the grade for mine yet, and I did get your email saying that I accidentally posted like the wrong document, but I sent you the right document via email.
You did, and I graded yours. Did I not? Okay, I wonder if what I did was I initially entered it in under the aerobic training one, and then when I went back to do aerobic training ones, I did that. But no, I've got it and it's graded, so I'll make sure I get that entered in, okay?
Okay, thank you.
You're very welcome.